Hello, my name's Jonathan Tan, and I'm a pediatric anesthesiologist at the Children's Hospital of Los Angeles and the Keck School of Medicine at the University of Southern California. And I'm really excited to be able to present to you today our work on spatial linkage of electronic health records and census data in a children's hospital. Just some disclosures. Funding was received from the McCabe Fund Grant at the University of Pennsylvania, and much of this work was conducted at the Children's Hospital of Philadelphia and the University of Pennsylvania, where I was previously on faculty. To begin with, social determinants of health is an important part of understanding the care that we deliver in a hospital setting. Much of our recent understanding of social determinants of health have us thinking that these are factors that occur outside of immediate medical care that may influence very strongly the health and health outcomes of our patients. For example, items such as economic stability, education, social and community context, health and healthcare access, and the neighborhood and built environment in which our patients and families live may influence health and health outcomes dramatically. These are items that actually many organizations are working on and have initiatives to help close this gap and do further research into understanding how social determinants of health improve care. And so what we wanted to do was to say, how can we further understand, study, and improve on social determinants of health in a hospital setting? The problem really lies in the availability of data. This is a study conducted by Samuels et al. In 2015. And like most studies that look at demographic factors, Table 1 shows very similar variables. I call this a demographic data problem, and it's not unique to this study. It's unique to studies that have been published elsewhere, including studies that I've conducted myself. And it really speaks to the fact that there are certain patient demographics that always seem to be reported. And these are important demographics, but they are limited. For example, most studies really do talk about race, ethnicity, age, and a payer status, whether it's government insurance, such as Medicaid or Medi-Cal or Medicare in the United States, or private insurance. The problem is much of this is actually used because of the limited amount of social, economic, and demographic factors that exist in electronic health records in the present state. Items such as educational status, the neighborhood that they live in, the built environment, and their ability to access healthcare, and other factors don't exist in our normal electronic health records, and that's a problem. So if we try to understand how we can actually do better with this, we tried to look back at strategies for leveraging information in pediatric electronic health records for social determinants of health to understand where is the data and how we can actually get better data. Our first option was to look at basic EHR data. And as I showed in the previous slide, this is extremely limiting because we just simply don't record further variables about a patient's social status, economic status, or demographic variables that may be very important in influencing care. We could survey individuals, but as one might imagine, this is very limiting when we think about doing this at scale for a healthcare system. Surveying individuals can be expensive, time consuming, and it could be uncomfortable for families to actually share specific items about their social and economic status. However, we have actually done this to help understand our patients, although at limited scale. You could employ natural language processing, which is a technology that's used to harvest free text in notes, identify trends, and further elucidate factors about their social and economic status. However, this is extremely limited by the fact that that information has to already be documented. Now that can exist in social work notes or primary care notes. However, not every patient may actually have information in which we can glean and apply natural language processing. And lastly, something called geospatial analysis. So for those who are not familiar with this, geospatial analysis employs technologies such as geographic information systems, which is a computer-based tool to capture, store, manipulate, analyze, and visualize geographic information, usually in the form of a map. For example, this is the state of Texas. There's a map there, and there's some data tables and variables that we could ascribe to that map based on location. And then we can find on the other end, deeper insight visually and mathematically about something that we are looking at. So we wanted to apply this actually to our patient population and try to understand how can spatial information and spatial linkage of data actually help improve the care that we provide. And briefly, how does geocoding work? The process of putting a location on a map. For example, at the Children's Hospital of Los Angeles, which is at 4650 Sunset Boulevard, we can actually take that, understand and ascribe a latitude and longitude geographic position for this hospital onto a map. And we actually did that with our patients in our study in order to understand where they were coming from and the neighborhood around them. Here's a case example that we'll talk about. Preoperative fasting duration. This is a very hot topic amongst pediatric anesthesiologists and pediatric surgeons, where we are trying to optimize the duration of time that kids have fasted for. For example, if kids fast before surgery and don't fast for long enough and don't follow our instructions, there's a risk of aspiration and a cancel case. And so kids get delayed care. However, if they fast too long and it's excessive, it could lead to low blood sugar, hypovolemia, hypotension, low blood pressure under anesthesia. The children could be irritable. Parents would be very dissatisfied. And it could lead to more IV attempts during surgery in order to put an IV in place for the surgery. So there have been several studies, and my colleagues at the Children's Hospital of Philadelphia, Dr. Isserman and others, actually tried to improve the amount of time that people are fasting for and optimize that. And so just real briefly, they changed the language of instructions before surgery. They offered drinks before arrival to the hospital. They offered more drinks in the preoperative area. And then they added other drinks as well. But truth be told, at the end, the number of kids that they wanted to optimize in terms of fasting steadied around 60%. So about 60% of the patients at the Children's Hospital of Philadelphia in the study were following the instructions appropriately in terms of their optimal fasting duration. The question was, how do we improve upon that? And if we look at our patients, are they all the same? And are the instructions that we're providing them able to be received appropriately and properly? And are there social and economic factors that may actually be related to how they're receiving their instructions? And do some families who are not compliant with our instructions, are they missing out on ideal and optimal care because of their social and economic status? And so we wanted to use unique, novel, and innovative methods of geospatial analysis to approach this problem. So in this particular study, we did data linkage via spatial join. It's essentially spatial linkage. And we took data from our electronic health records from February 2015 to May of 2019. This is for non-cardiac and non-emergency surgeries. So kids who are scheduled to have elective surgery during this time period. And we chose kids within a 3-hour drive time. Our hospital in Philadelphia drew from a much larger base of patients than just a 3-hour drive time, but we wanted to focus in on the majority of our patients, which do come from a 3-hour drive distance from our hospital. And what we did was we took electronic health records, individual data that's very granular from our hospital, and we wanted to combine them with our neighborhood data. So we used census data from the American Community Survey, which is a rolling 5-year survey. And in our particular case, ours was the American Community Survey from 2017. And essentially, we put these data sets together using data linkage via spatial join based on the latitude and longitude of our individual patients, which we know about from our electronic health records, and census data as a proxy for understanding their social economic status in the environment around them. Just real briefly, the way that the U.S. Census Bureau geographic entities work is that we are focusing really on a block group. So the unit of analysis for our study in our neighborhood was the block group. In a major urban environment, such as Philadelphia or major cities in America, that's talking about 500 to 1,000 individuals in your immediate area. It is the finest and most granular geographic entity that the U.S. Census Bureau releases, really because of protecting the individuals and confidentiality. And what we found was we had 41,000 unique patient encounters and approximately 34,000 unique patients in our data set. So clearly some patients came more than once for surgery, which is not uncommon in pediatrics. There, we've identified individual level risk factors from our electronic health record. And so factors for prolonged fasting included time of day of surgery. So kids in the afternoon had a longer fasting time than kids who had surgery in the morning. Kids with a younger patient age had longer fasting times as well, and males more than females had prolonged fasting. So this is data that we would normally be able to get from an electronic health record, and they're important variables. But are there neighborhood level factors that might help us understand the socioeconomic risk factors of our individuals? So look, using GIS, our patients came from this 3-hour drive time using Network Analyst from Esri's ArcGIS software. And we see that many of our patients came from as far as New York City, up above where the Statue of Liberty is, and down below where there's an icon of the White House in Washington, D.C. And our hospital is indicated in Philadelphia as the icon with the letters C and H. And we found that if we mapped all of our individual patients in our data set, there are about 34,000 of them. They're represented by each of these gray dots. And then we broke that further down into those with a very prolonged fasting time, so more than 4 hours in our definition. And these individuals, there are about 9,559 individuals in the color red. Now in the color green, those are the patients with a shorter fasting time. And so we had found out that longer travel time and distance was associated actually with shorter fasting durations. And that was interesting to us. And then we tried to understand what the social and economic factors were. So this is the city of Philadelphia itself. And while we did the study for a larger environment, it's easier to visualize if we just look at the city of Philadelphia. And so again, we see our hospital located at the bottom there with the letters C and H. And the colors represent the socioeconomic status variable of block groups with the percent without car and fasting duration. And we find that there are pockets of our city that have a higher percentage based on census data of percent without cars. And we found here that in this essentially bivariate analysis, that those areas with a higher percent without a car had a longer fasting duration. And conversely, those with a low percent or those with more likely to have a car had a shorter fasting duration. And now if we took these proxy variables of socioeconomic status, like whether you own a car or not, we could start building a map. What does unemployment look like in your neighborhood? Public assistance, single female head of household, low income, high school dropouts, rental occupied homes, and moved in the previous year. And you can imagine we started to build a map using census data and our individual electronic health record data to understand and find deeper insights into our patients' social and economic status. And then we built a map based on this social disorganization index by the block group and fasting duration. For example, on this three-dimensional map, these blocks actually don't represent building heights. They're actually a map of our social disorganization in our city by census and by block group and fasting duration from electronic health record data. And what we can see here is that just to the left of our hospital, there are very dark shades of blue, and the darker shades represent greater social disorganization index values. So essentially the lower socioeconomic status neighborhoods. And the heights represent less NPO duration. So in an equal world, we would love to see every block group height to be exactly the same, meaning every patient had the same fasting duration and that was equal across the city, but we don't see that. We see variation. And the ideal state, every height for every city block group would actually be equal and high, meaning they had very short fasting duration, which is optimal for our patients before surgery. But we don't see that either. In fact, we see variation in that as well. And so, for example, if we have an individual coming from West Philadelphia, which has a lower socioeconomic status, compared to an individual that might come from a lighter color area, which represents higher socioeconomic status, we actually find that in these two different quintiles, that there's a 41% chance that the person's more likely to have prolonged fasting time than in the higher socioeconomic status area to the right. And so we can use this information to provide deeper insight to how we should approach our patients. And so we think that EHR data plus census data yields better social determinants of health insights. And that is really leveraging the technology of data linkage using spatial analysis. And we are bringing together EHR data and census data to improve our understanding of how our patients are doing from a socioeconomic perspective and how that might be associated and influencing patient care and patient outcomes. And we hope to do this actually for many studies. And the next step beyond this is to actually, now that we can identify those individuals and their families and their risk from a socioeconomic perspective, that we can start to intervene and improve care, reduce disparities, and take better care of our patients. Thank you so much for your time. No work is done as an individual. We have a fantastic team of colleagues, and in particular, I'd like to thank these 8 individuals, including myself, for this work, and I really appreciate their friendship and their collaboration on this project and many others. Thank you so much. Please reach out to me via my email or Twitter account, and I look forward to hearing from you and furthering this discussion about how we can improve the care that we deliver to our pediatric patients using data linkage. Thank you so much.